Hello, hello, good evening, everyone, and welcome to our show tonight. I am so excited to be here. I was just laughing. I got a text from someone. Thank you. So I'm glad that you are here. Hopefully you had a great day, had a good weekend, and a good week actually since we saw you guys last. I am excited because we have a show tonight. We're going to be talking about one of my favorite topics to discuss, and that is diabetes medications. Everything you ever wanted to know about diabetes medications. If you are new to the channel, I'm Dr. Dwain Woode, and I am an endocrinologist, and I help people understand their bodies so that they can take charge of their health, avoid complications, and live healthy, fulfilling lives. So we're going to be talking tonight, like I said, about diabetes medications. There are almost 500 million people, that's 500 million, almost 470 million people around the world that are living with diabetes. In the United States alone, we keep saying that it is 34.2 million people. November is Diabetes Awareness Month, and so all this month we're going to be spending time talking about different aspects of diabetes. And as an endocrinologist, we see a great number of diabetics in our practice. So it's one of the topics that we spend a lot of time talking about. Also, if you are new to the channel, you should know that we answer questions here. That's what we're here to do. We're here to help you understand your bodies. So if you have a question, go ahead and put it in the chat and put a Q in front of it so that we know that that is a question that we need to get to. If you are new, go ahead and put new in front of your name, and we will be happy to welcome you because we love when we have new people coming by. Also, if you have not done so, please remember you can go to all of our social media platforms. You'll see something a little different, and we have across all of our platforms, our branding has changed a little bit. It used to be called Dr. Dwain Woode, and it's really now just called Dwain Woode MD. So that is LinkedIn, TikTok, here at this channel on YouTube, our Twitter channel, and of course buymeacoffee.com. You can reach us there, Dwain Woode MD. And if you've not already checked out some of our other offerings, every Monday night here at 7 o'clock, of course, is our show, our live show where we answer your questions. We also have our TikToks that come out at 10 a.m. on Fridays. And then every morning at 9 a.m., we have our Twitter feed where we put out different things, inspirational thoughts, also different tips on different lifestyle things that you can do. Okay, so please go ahead and check us out on those platforms. Let's see who's here with us tonight. Hey, Maria. I see Maria. She's kind of saying hello to everybody. Let me see if I can get you on the screen, if I can get my mouse to work. There we go. I have to bring it all the way over on this side. Why is that not working, guys? Oh, here we are. So let me pull. All right, so we've got Yvonne who's with us. Hey, Yvonne, she says, hello, Dr. Woode. How are you doing? Maria, of course, is greeting everyone. Hi, Yvonne. It says you're an early board. Thank you for tuning in. And then Maria said, hello, everyone. Just remember to put the Q in front of your question. Type new if you are new to this stream. Glad that you are here. So let's go ahead and let's talk a little bit about what we're going to be doing tonight. Right. So tonight we are here to talk about diabetes medications, and this is going to be what we're going to be trying to attack. Talking about oral diabetes medications, insulin therapy, and non-insulin injectables. Right. So oral diabetes therapy, insulin therapy, and then non-injectable diabetes medications. You'll also see there that I listed non-prescription therapy, and I put an asterisk near it. We're not going to talk about that today or tonight on this show, but if you would like for us to cover that, and we will be doing a separate show, we'll be happy to do that. Just go ahead and drop those in the comments. Okay, so if you want us to talk about non-prescription, but we'll be dealing with the first three tonight: oral anti-diabetic medications, insulin therapy, and non-insulin injectables. Now, one of the things, like I said earlier, there are several million diabetics in just in the United States and then around the world. And over the course of time, we've had so much changing over in the treatment of diabetes. Last week, we talked a little bit about history, and we talked about insulin therapy, its development, the first person who was able to get the insulin therapy, and how diabetes has changed. Prior to our modern medicine era, so that is all the diseases that you are seeing right now, the number one cause of death and morbidity, right, was infection and or accidents, right? So people did not die from heart disease and diabetes and kidney failure and those. I mean, I shouldn't say they didn't. There were people who had those, but it was not as it is now. So most of the people who at that time died or had morbidity, it was due to infection or accidents. Now we've come into this modern era, and many of the diseases that we're seeing are diseases of our modern life. Okay. And so in the course of diabetes, over its increasing around the world, technology has changed, and there's so much research that's going on in trying to find ways to treat diabetes. Now, as we go through tonight, I want to say that as we're talking about diabetes medications, always, I encourage you to talk to your provider as we're giving answers to questions that you may pose, as we're giving examples of things that we're going to be dealing with here. But the number of medications for the treatment of diabetes has really kind of exploded. And so we want to spend some time tonight talking about some of those and what they do, what are some of the things for us to look at and be careful of, and some conversations for us to have with our providers. Okay, so once again, that's going to be kind of our outline. And let's just jump right into it, right? So we talked, this is our outline, so let's just deal with the first group. And so we're talking about oral anti-diabetic medication. And before I even maybe talk about that, let me say that, there's a guy by the name of Ralph DeFronzo. And Ralph DeFronzo did something amazing for us years ago. He came up with what is termed the Agonists octet. Prior to that, all of our thought about treating diabetes was attacking, or not attacking, but making the insulin produce more insulin, or the pancreas produce more insulin, or giving insulin therapy, right? That was our plan. And so Ralph DeFronzo came along and said, hey guys, listen, there are so many other things that we need to think of when we're talking about management of diabetes. And so a lot of the medications that we have available to us now today are medications that are trying to, in some form or fashion, influence something in the Agonists octet. So as you're thinking about diabetes medication, I want you to kind of keep that phrase in mind, Agonists octet. And so you'll see there on the screen that there are several medications that fall in this category. And I've listed just the major ones. There are others, like I don't have, some of the, I don't have acarbose, for instance, that's on here. But glucophage, everybody has heard about glucophage. Glucophage is the name for metformin, right? So those two names go together. Glucophage, metformin. And we talked a little bit about metformin in its effect on B12, right? B12 deficiency. But metformin is one of those medications, and the way it works is it helps your body to use insulin more effectively. So it's an insulin sensitizer, right? It helps your muscle to use insulin more effectively. It decreases the amount of sugar that your liver produces, the capacity of the liver. The liver takes, when you need sugar, it goes through this process and it pumps liver sugar out. And there's a process or a form that goes there. We won't get into that, but essentially it produces more insulin or more sugar in the body. And so glucophage has the effect of decreasing the amount of sugar that it produces. And so those are two very important things, because we see glucophage being used in lots of different places. We see it used not just for diabetes, for the management of blood sugars. We also see it used in people who have PCOS, right? We see it used in patients who are trying to lose weight. So some of the weight management programs will use glucophage as well. Okay, we see it used in gestational diabetes for moms who are pregnant, who have elevated blood sugars before they get to insulin or some of the other therapies that may be available. Then glucophage or metformin is used there as well. So it is one of the older drugs that we have access to. Recently, there was a recall, and everybody is talking about this. The recall was not for necessarily the metformin or glucophage. It was for some contaminated lots. So at some place, one of the factories, there was some contamination found, and so there was a recall on that lot or that group of products. Okay, so it was not that glucophage or metformin itself was recalled, but because there was some contamination that happened. Okay, one of the things that you will find is sometimes if you begin taking glucophage, you may have some loose stools or sometimes even some nausea, and so we tell people that they want to make sure they take it, if they're having that, take it with food, right? So take that with food, and that may alleviate some of the things that you see. All right. So that's glucophage. Let's see. Do we have, and where did my screen go? Let's see, all right, there we go. All right, so that's glucophage. So once again, if you have any questions, go ahead and put those in the chat. We will get to those. We'll answer those. We have some questions that we have, some frequently asked questions that we're going to get to. All right, so let's go back and let's talk now about some of the other drugs that you may see on the screen. One is called TZD, or thiazolidinediones. And this group of drugs actually has a pretty interesting history because it was very effective in the treatment and management of blood sugars. And once again, these medications, all we're talking about patients who have type 2 diabetes. So TZDs were very powerful drugs that were on the market, and there was one that was pulled off the market, a second one that was pulled off the market, and not used as much anymore. And this is the class of drugs that necessitated that all drugs following that were coming out for diabetes had to prove that there was safety in for the heart. Okay, because these drugs caused some problems for people who took them in terms of their heart, and so as a result, all drugs that were developed post this had to prove that they were safe for the heart. But the TZDs were some very powerful drugs. They worked well. In fact, for some of the patients who were on TZDs, when we took them off and we tried to find other medications to treat their blood sugars, we had to put them on multiple medications to replace that one. Right, so that's how powerful they were, and we still see in some places see some patients that are on them. The next group there is the DPP4. The DPP4s are a group of drugs, and we'll talk about a cousin to this drug here coming up in a minute. This is a group of drugs that help the body to decrease the amount of sugar that comes out the liver. Once again, helps to sensitize the body to the use of insulin. And if your body is able to produce insulin through the pancreas, it helps the body or tells the body to do that. And then perhaps one of the newer classes of drugs, and you may see this on television, and I'll come back here in a minute and I'll go through and talk about some of the names. Okay, so I've not done that. I've just been putting the categories. So SGLT2s, and you are probably seeing some commercials right now about SGLT2s, and they are relatively, and when I say relatively, I'm talking within the last, 4 or 5 years or so, are drugs that have come out and are a wonderful addition to the group of medications that we use. And I keep saying the word drugs, right? So you'll excuse me, I use those terms, drugs, medication, interchangeably. You'll see these medications come out, and they are a wonderful addition to the armamentarium that we have to manage blood sugars. Now, let me back up and let me say one thing, okay? And there are some of you right now who are watching this, some of you are listening, and the hairs are standing up on the back of your neck, right? Because we're talking about medication. Right? And I want to preface all that I say by saying this. Our goal is always as little medication as possible. Right? So that's what we want to do, as little medication as possible. As we're doing that, though, there are times when medication is needed and necessary. Okay, so if you need medication, let's use it until we are able to do some of those other things that we can do to manage blood sugars. All right, so don't get it bent out of shape as we're talking about medications for the treatment of diabetes. Some people need it, and if we don't have it, we can have lots of difficulty, lots of problems in our management of the diabetes. Okay, all right. Let's see. All right, so that's TZDs, SGLT2s, and the way SGLT2s work is that they take sugar and they put the sugar into the urine, right? So the body's trying to get rid of sugar, all right? The blood sugars are high, and so it takes sugar, it puts it into urine, and essentially you pee it out, right? So that's how those work. All right, so let's see. I am going to hop over here and let's see if we have one of these questions that we had submitted. I'm going to pop my screen back so that you see me. Here I am. There we go. And then let's see. Let's pop this one up here. Let's see. Where did we go? All right. Guess we got to get the questions first, right? Where do we go? Okay, here we are. I think this is it. Let's see, what does this one say? All right, guys, I'm having some trouble finding... okay, here we are. Let's take this one. Let's see how we answer it. All right, so can my diabetes medicine cause low blood sugar? Wow. So can my diabetes medication cause low blood sugar? And the answer to that question is a resounding, what do you think? It's a resounding yes, right? Because one of the side effects, one of the ways that medications work, diabetes medication, is that they lower blood sugars. So, of course, one of the side effects of diabetes medication is low blood sugar. Now, there are some medications that cause blood sugars to go low more often compared to others. And we'll get to one of the classes here in a minute when we start talking about insulin. But insulin has an unlimited capacity to lower blood sugar. But all of the medications that we have the ability to lower blood sugar and can cause lows. There are some that are less likely to do so compared to others. Okay. But generally speaking, the answer to that question is yes. Let's see. Here's another one. If I'm sick and can't eat, should I still take my medicines? Whoa, okay. So if I'm sick and can't eat, should I still take my medicine? So once again, for all of the questions that we are answering, we're going to say, please, please, please make sure that you check with your provider in your specific case, right? But generally speaking, for patients who live with type 1 diabetes, they require insulin. Okay, so their problem is not necessarily a food problem or a carb problem or a sugar problem, right? The high sugar is a consequence or a result or a symptom of the fact that they have another core defect. And their core defect is that they lack insulin. And so they have to take insulin. So there are times where we will have a patient who is a type 1 diabetic. We will have them try to sip on sugary beverages, right? So that they can get their blood sugars up so that they can take the insulin. Because remember, their problem is not the sugar. Their problem is the insulin. Now, in any of those cases for you guys, as you're listening to this question, we want to make sure that if you're not able to keep things down, right, that you are seeking medical attention, because you can get into trouble relatively quickly if you're not able to take anything down, if the blood sugars are high, and particularly for our type 1 diabetics, you want to make sure that you are seeking help as soon as possible. Because if you are able to get help and they can help with the nausea and vomiting, and you can begin keeping food, drinks down, you can take your insulin, we may be able to help you manage this at home. So if you go to the emergency department, for instance, they can get you some treatment and maybe send you home. But if you wait for a long time and you're throwing up and throwing up and throwing up, then you can get into ketosis really quickly, or DKA. And so by the time you show up in the emergency department, that's an admission to the hospital. Okay. For our type 2 patients, it depends on what your blood sugars are doing. It depends on what type of medications you're on. So there are so many factors that play into that. But once again, if you're throwing up and you're not able to keep anything down, that's an indication that you should seek help as soon as possible. And that may mean going to the emergency department, an urgent care, or somewhere where they can give you some help. Very good. Good questions, guys. Let's see. Yvonne's. So Yvonne says, I was just wanting to know what foods can I eat at night that won't shoot up my glucose. I have controlled my sugar level nowadays. Okay, so so Yvonne, if I understand correctly, you have blood sugars that are relatively well controlled, and you want to know what can you eat that will not shoot your blood sugar up. And this is at nighttime. Now, one of the things that a lot of people find is that they go to sleep with blood sugars that are relatively good, and over the course of the night, while they're sleeping, they wake up with blood sugars that are higher. And a lot of people will get frustrated sometimes because they say, wait a minute, I didn't eat anything. So why is my blood sugar higher now than it was when I went to sleep? And one of the answers to that is that your liver is producing sugar as you sleep. Right? One of its function is to help keep you alive. And so it produces sugar as you sleep. And that's why sometimes people will have higher sugars in the morning than they had at night. The other thing is that as you are getting ready to rise in the morning, and you may not know this if there's no way to monitor blood sugars overnight. As you get ready to rise in the morning, there are hormonal changes that go on in your body, and those hormonal changes are with the intention of getting you ready for the day, right? So you got to get you out of bed, get you dressed, you got to comb your hair, put on your clothes, and you got to get out to work or school or wherever you're going. And so those hormones are used to do that in the body. And sometimes you'll see that you have higher numbers as a result. Now, so back to the question, though, of what types of things can you eat? And so you want to try to eat things that are low carb, right? Things that are more protein. So sometimes people will eat nuts. Now, nuts and nuts kind of get a bad rap because they do have carbs in them, but they also have protein. And so a handful of nuts. One of the things that people talk about staying away from because of inflammation and so forth is cheese. But cheese also low carb, but that can help with a snack overnight so that you're not raising those blood sugars. Or you can find some green leafy vegetables that you can eat. I was thinking, someone said recently to me that they eat carrots. Carrots may not be a good one for you. Now, here's the thing about all that we do in medicine. there are some rules that are there. There are some principles that are there, but there are people who don't fit within those, right? So there are some people who can eat carrots as their snack and nothing happens. And some people will eat, cheese or nuts and their blood sugars will go up. And so Yvonne, you really, with those as guidelines, you really have to kind of find the thing that works best for you. But good question. I like that. Okay. And let's do one more and then let's get back to our topic. So what should I do if I forget to take my medicine? All right. What should I do if I forget to take my medicine? And once again, I know I'm beating this horse, right? Check with your healthcare provider. So generally speaking, if you forget your medicine, we tell people, for instance, if you're taking it twice a day, just take the night one and then start back in the morning. Okay. Now, once again, this depends on what your blood sugars are. It depends on the medicine that you're taking and so forth and what else is going on. Okay. So if you forget your medicine, follow the direction of your physician. For most of the things that we have our patients on, there's some that we do tell them to take it in the morning before their first meal. For instance, I just mentioned Glucophage. So if you take Glucophage in the morning and you remember, 10, 11 o'clock, and you normally have upset stomach when you take your Glucophage, then you may need to wait until after that lunch meal. Okay. But for Glucophage, I would say take it. All right. So that's a very good question. Very good question. All right. So we talked about our oral anti-diabetic medications. Let's talk a little bit about insulin therapy. Insulin therapy. And we talked last week about the fact that insulin was developed in the 1920s, the first patient that had the first dose of insulin, and how insulin has changed really the course of diabetes from being this acute death sentence that people had to more of a chronic illness. And so people are living healthy, long, normal lifespans on insulin. Which is a wonderful thing. So insulin, there are two types of insulins that you will run into. There's basal insulin and there's bolus insulin, right? So those are kind of the big categories. You'll also hear them termed long-acting or short-acting, long-acting, intermediate-acting, short-acting, rapid-acting, right? So those are all phrases that you will see. But essentially, the role of insulin is to help to normalize blood sugars. Because remember, in patients who live with type 1, their issue is they don't have insulin, right? So they don't have insulin, so their blood sugars are elevated, and because those blood sugars are elevated, then they get the complications that we see with high blood sugars. And for type 1s, because they don't have any insulin, there is no other way of getting that sugar into the cell, and so the cell can't function and do the things that it normally does, right? So that's type 1. Type 2s, because their insulin is not as effective, we give insulin with the intention that really the sheer force of the extra insulin will almost, if you will, push or force the sugar into the cell, right? And that's a crude example, but that's really what we're doing. We figure if we can give enough insulin, right, to overcome the resistance that the people are seeing in their bodies or feeling in their bodies, then we can get some of that sugar into the cell. All right, so that's the idea. The idea of basal bolus. So basal is an insulin that we use over the course of 24 hours, and there are some insulins that are longer acting now, but over the course of the 24 hours to try to keep the blood sugars, if you will, at bay, right? So they don't rise too high. Now, one of the benefits of basal insulin, one of the drawbacks of basal insulin is this. The benefit is that if you don't eat, a lot of times basal insulin may be enough, right? Because it's that 24-hour insulin that's kind of keeping the blood sugar at a certain level throughout 24 hours. But if you start eating, you begin getting these spikes, right? So the blood sugar doesn't stay nice and easy or even. And so bolus insulin is the insulin that is there, and bolus insulin helps to manage the blood sugars based on those spikes. Okay. Now, there are other things that can cause blood sugars to rise, and we've talked about this, and we'll do another show on this. But there's so many different things other than food that can cause blood sugars to go up. So there are times when you're not eating and the blood sugar does rise and you still have to treat it. And often the bolus insulin is what is used for that. So you may hear things like Lantus or Toujeo or Basaglar or Levemir. Right, so those are some of the long or basal insulins, and then the shorter insulins you'll hear Humalog or Novolog or Limjev or Pedra. Right, so those are the shorter acting insulins that we use for boluses and to help to manage those blood sugars. Now, so the benefit we talked about that of insulin is that we're able to get those blood sugars down. Now, insulin is a growth factor, and insulin can cause some other issues. And we said that insulin actually is one of the medications that has an unlimited capacity to lower the blood sugars. So you can actually have low blood sugars on insulin if you are not careful, right? So insulin, wonderful. When it came along, the therapy for diabetes really changed, and the therapy became amazing for patients, right? So patients were living longer. And so we now are using it, and insulin is used now more for kind of chronic therapy, right? For our type 2s, because there are more patients with type 2 diabetes that's on insulin than type 1s. Okay. Very good. Very good. Let's see. Let's get back and see. Oh, so Yvonne asked another question. She said, I'm just tired of eating chicken and lettuce for dinner. Hi. Yes, Yvonne. So eating chicken and lettuce can become very, I'm not going to use the word boring, right? It can be interesting. So one of the things in anything that we do when we talk about the management of diabetes is that we always talk to patients about variety, right? So finding different ways of cooking the food that you're eating. And we also talk to them about being able to, I don't want to use the word overcome, but that for lack of a better word, we want to make sure that you are doing things that you can do long term, right? So there are a lot of people who, when they're diagnosed, at some point something happens, and they, if we think of the treatment of diabetes as a pendulum, right? And you can be way over on one side in terms of what you're doing that is quote unquote not doing the right thing, or way on the other side, ultra extreme. And so most people, when something happens, they go to one extreme or the other, right? And what I encourage our folks to do is to try to find somewhere in the middle. Now, of course, the things that are your weaknesses, right? So if and I'm going to tell on myself, right? So I love ice cream, right? And there's a particular brand of ice cream, I'm not going to say it, right, that I really like. And I don't bring that to the house. Now, we bring other ice cream to the house, but I don't bring that to the house because I know if I do, it's all over, right? So you've got to know yourself, and you've got to be able to say, hey, look, I'm going to try not to bring that. And so you've got to be prepared. The management of diabetes, when we're trying to make changes, it takes preparation. It takes it takes order, right? So you can't wake up one morning and decide, okay, I'm going to do this. Because what happens is you go through the day and it may become frustrated because you've not prepared for it. You say, oh, this doesn't work. And it's not that it didn't work, it's that you didn't prepare for it. Okay, so I know that's a long answer to your question there, Yvonne. But that's one of the ways to kind of think about it. And hey, we got Mommy Guide. Hey, Miss Lala, how are you? She says, hi, Dr. Dwain. Yay, finally got to catch you live. We are so glad that you are here. Welcome. Guys, if you've not checked out Mommy Guide, you hop over to their channel sometime and and go ahead and follow, watch them, subscribe. It would be awesome. All right, what did she say? She says, indeed, we don't need to fight temptation if it's not there. So don't buy or put it within easy reach. Oh, yeah. And I'm so, guys, let me tell you, I'm guilty of that, right? So, because sometimes I will get stuff and I need to also be following a lot of this, right? Because it happens to us all. It happens to us all. All right, so let's get back to our outline. So we were talking about, so we went through our oral anti-diabetic medications. We talked a little bit about insulin, and then we're going to now talk about non-insulin injectables. Now, let me pop back here for a minute. And let me say, so we mentioned metformin, glucophage, right? So the SGLT2s, those are things like Farxiga. What did I do? Yeah. So those are things like Farxiga. Those are things like Jardiance, Steglatro, right? So those are SGLT2s. And of course, the DPP4s, you've got Januvia, you've got Onglyza, you've got Tradjenta. That falls into those categories. And the two that I mentioned under the TZDs would be Actos and Avandia, right? So Actos and Avandia. All right. So let's hop over here and talk about GLP-1 receptor agonists. And so the GLP-1 receptor agonists and the DPP4s go together because so there's an enzyme or there's a peptide in the body, let me start there, that helps to manage blood sugars. And in patients who have type 2 diabetes, that is deficient. So one of these medications gives you back the enzyme, and the other one stops an enzyme in the body that breaks it down. So essentially, we're giving you the missing enzyme, and then we're protecting it. Right, so those two medications, that's what they do. And you'll hear, a lot of people will talk to you, or pharmacists or the insurance company, or people will say to you, "Hey, you shouldn't use them together because they do the same thing." They do not do the same thing, right? They work in totally different ways. Now they have the same end result, right, of keeping that enzyme elevated for people who are missing it, but they don't work in the same way. Okay. So if you ever hear that, they're not working the same thing. They're two separate forms of action. And so GLP-1 receptor agonists, this has actually been one of the classes that, and I'll come back in a minute and talk about some of the things that you're seeing on TV with some of these medications. This is one of the classes that came along, and it was really kind of a surprise. And so they started working well, and people have been studying them. And so the way these work is, one, we talked about the DPP4s earlier. They decrease the amount of sugar that your liver produces. They help your body produce insulin if it can. They help your body use insulin more effectively. And the other thing that they do is they slow the food as it moves through your stomach and your GI tract. So it slows GI motility. I'm going to pause there for a second. Slows GI motility. So a couple of things readily you can see there, right? So number one, if it slows motility, people feel fuller longer. Yeah, and so we use that as a way to help people lose weight, right? So there are patients who have good blood sugars, so the A1C is controlled, but we may switch them to a GLP-1 receptor agonist because it continues to control their blood sugars, but it also makes them feel fuller longer. And because they're fuller longer, they don't eat as much, and so their weight begins going down. And you may see on TV, there is one of the GLP-1 receptor agonists that was approved specifically for weight loss. Okay. And so people are using it not just in diabetics for the treatment of their blood sugar, but they're using it also for patients who may want to manage their weight. Okay, so that's how the GLP-1 receptor agonists work. So the other thing is, so let's talk a little bit about, so that's a pro. So it helps manage blood sugar. It also helps with weight. Okay, now not all of them are indicated, but we think it's a class effect, and so even though all of them don't have the indication for weight loss, a lot of us will use them in our patients for the weight loss. Okay, so those are the benefits. Now we talked about them slowing motility, so stopping or slowing the food as it moves through your GI tract, and you can see that can show up in some people as nausea. Right, so they feel kind of this queasiness. It also can cause some abdominal pain because some people's GI tracts are very sensitive, and so they can have nausea. Maybe some people will have vomiting. Some people will have abdominal pain, and in severe cases, they can have kind of pancreatitis. Right, but the drug in itself and the class works very, very well. And in this class, we're talking about things like they're once a day ones, so Victoza, twice a day ones. You got Byetta, there's Bydureon, Trulicity, and Ozempic that are once weekly. Okay, so that's one of the benefits of them, that they are once weekly. Most of the other things we talked about so far are things that people use on a daily or once a day or twice a day. Okay, so you'll see those. Let me back up and let's talk a little bit about these guys and the SGLT2s. This has been a breakaway class. Okay, so everybody's doing a study on SGLT2s right now, because SGLT2s have been indicated now for helping with coronary artery disease, to help with heart failure. There's SGLT2s that are being shown to help with kidney function and to preserve kidney function. So many different things that are going on with them, and you'll probably see those on TV. So Farxiga, Jardiance for the SGLT2s. For the DPP4s, you may see Tradjenta that are there. For the insulins, like we already mentioned, Tresiba, Toujeo, Basaglar, Lantus, and of course for the boluses, we've mentioned those. And over here we're talking about, like I said, Trulicity, Ozempic, Byetta, Bydureon, Victoza. So those are the most common ones. And then now there are even combinations. There are ones that have both long-acting insulin and GLP receptor agonists in them. So like Soliqua, all right, that's one that you'll see. All right. So let's pop over here and let's see what we have. Let me see if I can catch up here. So we've got some Mommy Guide. So we talked about this. Mommy Guy said, indeed, we don't want to fight temptation. Maria said, woohoo, hi, Mommy Lala. Oh, look at this. Blind guy, his wife, their lives. This layout is my favorite, by the way. Oh, thank you for coming over. And I'm still waiting for my front seat tickets, by the way, guys. I don't know. Corey, you and Laquita need to talk about that. All right. And Cecilia... Maria said, blind guy, the wife. I agree. Love it too. And welcome back. Thought I'd missed you today. I said, I'm here listening and realizing I hadn't said anything, but hello to everyone. And so wave. And then Xanthine07. Hi there. It's me, EJ. I'm signing up with my personal YouTube account. Awesome. Well, thank you for joining us. And Maria saying hi. And then hi, Lauren, are you in too? So this is a great point to just stop for a minute and then pop this up on the screen. So once again, guys, as I mentioned earlier, if you've not already done so, please go ahead and hit us up on all of our social media platforms, and you'll see a little bit of different rebranding, some subtle changes. We were Dr. Dwain Woode. All of our social media now is Dwain Woode MD. So Dwain Woode MD on our LinkedIn, TikTok, here on our channel, on YouTube, our Twitter, and of course, buy me a coffee. If you've got something you want to send us via email, DwainWoodeMD@gmail.com. And if you'd like to see more exciting content, of course, always join us here Monday nights at 7 p.m. for our live stream, our TikToks that go out 10 o'clock on Fridays, and Twitter that goes out 9 o'clock every morning that has, inspirational thoughts. We've got some tips and tricks there for you on general life. Okay, so thank you guys once again for coming. And if you've not done so, go ahead and subscribe, hit our bell, and we'll love to see you. And welcome to all of you who may be new. So let's get back to some of these questions. Okay, so let's see. Let's pop this one up. At what times should I take my medicine? At what times should I take my medicine? And a lot of medications are indicated twice a day. There are some that will say you should take it before your first meal of the day, like some of the insulin combinations with the GLP will say that. But really, it depends on your physician, because there are times when I would tell my patients to take their medications in a different way because of something that's going on in their particular situation. Okay. So once again, most of your insulin, the basal insulins, typically at night before bed or in the morning. Although I do have a couple of patients. I have one young lady who always, she was, how old was she? 15, 16. And so she always forgot to take her insulin. And so what we did is we sent it to school, and the nurse gave it to her at noon, right? So that's not according to, what we normally think, but it's a 24-hour insulin, and we just wanted to make sure that she got it. So she was taking hers at 12 noon. Your bolus insulins, of course, those are typically indicated with a meal, and so we want those to be before a meal. And so often we'll tell people to take those 15 minutes before the meal to kind of get it in the system, because if you start eating and then you take the insulin, guess what? The blood sugar is already on its way up, right? And so by then we can run into some other issues. All right, good question. Let's see, what do we got? How long would it take this medicine to work? And how long will it take medicine to work? It depends on the medication, right? Insulin works very quickly. And so a lot of times we'll give patients insulin, and within 15 minutes, we start to see those blood sugars coming down. The basal insulins, of course, take longer. The oral medications, depending on which one, they take time to get into the system. They've got to reach a steady state, or a therapeutic dose, if you will, and then they begin working. So it depends on which medication you're talking about. Most of the shorter acting insulin or rapid acting insulin or bolus insulin, all those phrases can mean the same thing. Those insulins will work within minutes. Okay, within minutes. Very good. Let's see. Here's another one. How often should I check my blood sugar? Once again, depends. It depends. It depends on your healthcare provider. We're actually going to be doing our show next week is going to be talking about self-monitoring of blood sugars, right? Self-monitoring of blood sugars. We're going to give you some tips and tricks on how to incorporate blood sugars into your life, because they're so important for the management of the diabetes. So make sure you catch us. Next week. Is there a combined CGM and insulin? CGM and insulin. I think that should say insulin pump, right? Combined CGM and insulin pump. And we didn't talk about, when we talked about our insulin therapy, right? So we didn't talk about insulin and CGMs, or continuous glucose monitors. Typically, for our bolus insulins, that's where the insulin pump will fit in, because we put the same kind of insulin as we use for the boluses into the pump, but the pump really replaces both the bolus and basal insulins. So that's a very good question. Like I said, we didn't talk much about pumps, but pumps are just another way of delivering insulin. And to answer the question specifically, there are pumps that work with continuous monitors, right? There are pumps that have a system that they work together, but there's not a single device that is a pump and a continuous glucose monitor in one. Okay, that does not currently exist. We are hoping that comes along, but not quite there yet. Okay. All right. Other than water, what can we drink? What can we drink other than water? So I'm gonna give you two answers to this. I'm going to give you the real answer, and then I'm going to give you kind of tongue-in-cheek answer with my fingers crossed and all that kind of stuff. So, no, really. So, water. Water, 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 water. How many times? When water, right? And after you've had some water, drink some more water. There is nothing that has the regenerative abilities, the cleansing abilities as water has. Okay, so everything else that you will drink has something that, and once again, it's not that it's bad, right? But the optimal thing is water. So people talk about, and one of the questions I think I put up earlier was drinking Coke Zero and Diet Cokes and diet drinks and so forth. And all of those, while they help to minimize or maintain good blood sugars in the immediate, they also lead to other issues like hunger, and injuring the gut flora and so many other things that can happen, right? So water, 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 right? So I'm drinking water now, and I've got to work on that myself, okay? So it's not something that just, it's something that we all have to work on, okay? Let's see if we can get a couple more of these. And we've got, can metformin make you feel physically sick? Well, metformin is one of those medications that has, because it's been around so long, there are so many things that people talk about, right? So they talk about whether, we already know that it seems that metformin can lead to B12 deficiency because of malabsorption. Metformin has been linked to things as varied as Alzheimer's, to cancers, to so many different things. And there's not been any scientific proof that those things are true. Okay, no scientific proof that those things are true. So when you are looking at metformin, there are things that can happen. So for instance, if you're having nausea, vomiting, diarrhea, if you are having malabsorption, of course you can have joint aches and joint pains and neuropathy because of low B12. So all those things are true, but those are not just general for the class of metformin, right? So those are specific things that can happen. All right, let's see. Let's pause here and let's see. So here's a question from Xanthine07. Is Byetta SA first GLP still work? Does it still work? What about the first oral GLP-1 receptor, Rybelsus? Right. So, you guys have seen that I've deliberately tried not to talk about a specific medication. I've given you the list, the categories. So all of the GLP-1 receptor agonists help to manage blood sugar, right? They do. And here's a little secret, right, guys? All of the medications, right, aside from insulin, all of the medications will lower your A1C between, 0.6 to about 1.4, 1.5. That's what they do. Okay. So the marketing that you guys will hear, you've got to be careful when you listen to those things. And one of the things that I hear on TV that sometimes will give a skewed view of different things is they say, hey, take this medicine and it will lower your A1C. Right? And everybody's preaching, get your A1C down, get your A1C down, get your A1C down. You cannot lower your A1C without lowering your blood sugar. They're not separate. So when you see the commercial that says, hey, we're going to lower your A1C, it has to be also saying we're going to lower your blood sugar. And if it doesn't lower the blood sugar, it cannot lower your A1C. That's just a fact, right? So once again, there is this. The marketing can be so insidious. It's there, and people kind of get the wrong idea. So diabetes management does not happen by magic. It doesn't happen by magic, right? So lowering A1C, you cannot do that without lowering the blood sugar. All right. Let's see. So, but to answer your question specifically, I didn't think I answered. So, Byetta, yes, it does work. Rybelsus does work, yes. Front seat to what? The play. Is that gone already? Okay. So Maria said, I was hoping you were going to say something else than water. Yes, Maria. I know a lot of people will say, yes, I want something other than water. So here's one from Blind Guy. It says, does tea count as water if we're brewing our own loose leaf tea? I'm back to English, by the way, now that we're not talking theory. Oh, okay. Yes. All right. So this idea of tea, right? Remember, there are still other things in the tea. For instance, tea has caffeine. Okay. So the caffeine makes you pee. And so even though you're drinking tea, it can still cause kind of a diuretic effect. So I'm not saying that you can't drink tea, but if I had the choice between tea and water, right, for health, then water is where I would be. Now, there are some very good benefits to tea, right? And that could be a whole show by itself. There are some good benefits to tea. But specifically, if we're talking about water or tea, then water. Okay. And maybe I'll come get some of your blends. I love that. All right. And then let's see. Why does insulin cause weight gain? Oh, insulin causes weight gain because insulin is a growth factor. So insulin causes weight gain because insulin is a growth factor. What is a growth factor? It's a thing that makes things grow. So when you take insulin, it makes things grow. Like what? Well, it makes fat cells grow. Why does it make fat cells grow? Because we take sugar now and we put it into the body so the body is able to process it. Before, all the sugar is running around in your blood. Now the body is able to process it. It goes into the cell packages it, and sometimes it gets stored as fat. Okay, so that's a growth factor. Insulin can cause you to retain fluid, right? So sometimes you're on insulin and fluid is retained. Insulin makes you hungry, right? Because insulin makes you hungry, you eat more, and so weight comes on. So several things that can go there. And then insulin triggers so many other different mechanisms or different pathways in the body. So it is a drug that we use for the treatment of diabetes. But remember, all medications, how many did I say? Yes, all medications. I said it for all you out there. All medications have some side effect. Okay, let's see. I'm on a medication that causes yeast infection. What can I do? I'm on a medication that causes yeast infection. And this is probably that person is talking about one of the SGLT2s. Remember, we talked about the SGLT2s because they take sugar and they put it in the urine, and that's how the urine, how sugar gets out of the body. And so when you do that, then you can have, yeast-like damp, dark places. And so it can cause yeast infection. So what should you do? You should talk to your provider and let them know. And typically we will treat people with diflucan to try to resolve that. If it persists, then those patients will have to come off of that medication. Okay, patients have to come off that medication. So let's pause here for a minute and let me give you my thought for today. So I heard someone say recently that they were feeling depressed, they were feeling lonely. This is one of our elderly people that we take care of. And she said, I've done all these things for so many people all of my life. And now that the pandemic is here, no one is coming out, no one is coming by, and I feel lonely. And the pandemic has really affected all of our lives in ways that we cannot yet begin to understand, right? So I've got a 12-year-old who, has been in the pandemic for the last two and a half years. And so everything that we're doing is to try to minimize the effect of the pandemic. And I want to encourage you, if you've not done so, there are people in your lives, there are people in your circle that you are kind of separate from, or people that you've not talked to in years. This is a perfect time for you to pick up the phone, for you to call them, for you to send them a letter. You guys remember letters? We actually used to sit down and write on a piece of paper, right? This is a perfect time for you to reconnect, because all the things that we do, all the things that we chase after, all the things that we think are the things that we want, nothing is more important than those connections. And the connections we make are the connections that make life rich. And that is why we manage diabetes. That's why we control blood sugars. Not just because we want the blood sugar control, because we want to keep you alive as long as possible. We want to keep you as healthy as possible so that you can enjoy your life, so you can take charge of your health, live healthy, fulfilling lives. And those lives are just enriched when you can connect with the people around you. We thank you for being with us tonight. This has been a wonderful, wonderful conversation. I've loved this. This is one of my favorite topics to talk about. And if there are other things that you want us to discuss, go ahead and put those in the comments, right? Share this video with someone you know who has diabetes, someone who's taking care of someone with diabetes. Ask them once again to, and I'm going to pop this up, to subscribe to our channel, to like us. And if you are interested in supporting us, remember, buymeacoffee.com. Thank you so much. Come and join us next week. We are happy to see you here. We are building a community where there's trust, where there's hope, and where there is good information. This is Dr. Dwain Woode from Diabetes and Endocrine Wellness Center and The Light Away, educating the public for a better you. All right, let's get some music and get on out of here. Bye, guys.